Welcome everybody. This is CVI 2020 and my assignment is Hindsight is 2020. I was asked to present to you a mitral challenge. These are my disclosures. Our learning objectives today will be to review embolization rates of valve VIMAC procedures using balloon expandable aortic transcatheter heart valves, to analyze predictors of valve embolization, and to describe strategies that may help prevent valve embolization after valve VIMAC. I'll start with a case. This is back from March of 2014. This patient was treated with transapical TAVR followed by transapical valve VIMAC with a first-generation device. And as you can see, this patient had embolization of the Sapien valve into the left atrium. Same year, we had a second case of valve embolization. This was a transeptal valve VIMAC, and the valve also embolized to the left atrium. This is a second-generation device. As you know, the TMVR IMAC Global Registry collected the early experience of these procedures, and we found that embolization occurred in about 4.3% of those patients, so 5 out of 116, and those accounted for half of the cases that needed conversion to open heart surgery. The TMVR Multicenter Registry from the group at Cedars-Sinai found an embolization rate of 6.9% for valve VIMAC, which was much higher than that seen for valve ring and for valve valve. This is a more contemporary report from data from the TVT Registry. We analyzed outcomes of valve VIMAC, valve ring, and valve valve, and we found an embolization rate of 3% in valve VIMAC, which was higher, particularly higher than mitral valve valve. And what we were able to demonstrate in the TMVR IMAC Global Registry is that outcomes improve with experience. 4 out of the 5 embolizations occurred during the first half of the experience and only 1 in the second half. And the reason is we learned the risk factors for embolization and some tricks to prevent it. An important risk factor is undersizing. We must oversize, as we do in TAVR, or perhaps even more. Maybe 15 to 25% is a good range of oversize. Another risk factor is underfilling. We should always deliver the complete amount of contrast into the delivery system. The case that you see on the left side was a patient that was treated with an undersized valve, and in addition to that, the complete amount of contrast was not delivered in the balloon catheter due to concerns of producing or causing annular rupture. So we learned that we have to fill these valves very well and add extra contrast to flare in the left ventricle. We routinely add about 2 cc's for the 23 millimeter valve, 3 cc's for the 26, and 4 cc's for the 29. Another risk factor is placing the valve in a 2 atrial position. Our goal is to position the valve 80% in the ventricle and 20% in the left atrium to prevent or decrease the risk of embolization to the left atrium. And last but not least is not enough calcium. If we don't have enough calcium to hold the valve, the embolization risk is high. But the question is, how much calcium do we need to anchor a Sapien valve in the mitral position? As you know, there are now other devices that are being used to treat patients with mitral annular calcification. Those devices are designed for the mitral valve and have anchoring capabilities which are absent in the Sapien family of valves. So for some patients, a treatment of valve VIMAC with a Sapien family valve would be adequate, but for some, it may not be adequate. So we decided to design a CT-based MAC score that could help us predict embolization of a Sapien valve in MAC. So we looked at 4 features. One is calcium thickness that you see on the left, then calcium distribution, trigon involvement, and leaflet involvement. And we provide points according to the severity. So for calcium thickness less than 5 millimeters, we assign 1 point. 5 to 10 millimeters is 2 points. More than 10 is 3 points. For calcium distribution less than 180 degrees, we assign 1 point. 180 to 270 is 2 points, and more than 270, we give 3 points. And then 1 point for each trigon involvement, and 1 for each leaflet involvement, anterior or posterior. So the total score is 10 points. And we consider mild MAC if we see 0 to 3 points, moderate 4 to 6, and severe 7 to 10. And you see here a few examples of what we would call mild, moderate, or severe MAC according to the score of 2, 5, and 8 in this particular examples. So we went back to the TMVR IMAC Global Registry patients and we analyzed those CT scans. We have 87 with adequate quality for analysis. We excluded the transatrial cases because during open transatrial procedures, the surgeons can place anchoring sutures, which would provide introduce bias into the analysis. So if we only focus on the transeptal and transapical cases, so a total of 72 patients, the mean MAC score in this patient population was 7.4, so we're talking severe MAC. And this is what we found. In green, you see patients who did not have embolization or migration. In red, those red dots represent embolization cases, and the blue dots represent migration cases. And we found that patients who had a MAC score of 7 or greater had a low rate of embolization or migration, or lower than patients who had a score of 6 or less, who had high rate of migration or embolization, up to 60%. So the vast majority of those either migrated or embolized. We then further analyzed them in two groups, undersized or not undersized valves. So the mean degree of undersizing in the undersized group was minus 15%, so it's significantly small. And in the not undersized valves, the average degree of oversizing was close to 12%. And in both groups, we found that patients who had a MAC score of 7 or greater had a much lower rate of migration or embolization compared with patients who had a MAC score of 6 or less, with an embolization rate or migration rate as high as 67%, even in the not undersized valves. And that was statistically significant. There were no embolizations in the group of patients who were not undersized. There were only a few migrations, and this is the rate of migration for patients who had a MAC score of 6 or less was as high as 66.7% and much lower if the score was 7 or greater. And we did multivariate analysis. We found that a MAC score of 6 or less was an independent predictor of valve embolization or migration. So we think that for patients who had a score of 6 or less, which we would consider mild or moderate MAC, would probably be better served by getting treatment with a valve that has been designed for the mitral position, that has some anchoring mechanism, and not a Sapien 3 aortic valve due to the high risk of embolization. And if the score is 7 or greater, then you have the two options depending on anatomy. You could either consider the Sapien 3 transeptal case, if the anatomy is favorable, or a mitral dedicated transcatheter heart valve. So going back to the cases I showed, this patient had a good score of 8, so a lot of calcium, but this valve was clearly undersized, and in addition to that, it was underfilled. So this valve embolized. The second case had a MAC score of 6, which by itself would put this patient at higher risk of embolization. And in addition to that, was also undersized, so double risk for embolization. So if I look back in time, or if I could go back in time, knowing what we know now, I probably would have treated this patient in a different way. But we cannot go back in time, obviously. But what we can do is, moving forward, we can utilize the knowledge that we have now so that you don't have to have this type of complications. So this is an evolving algorithm that many of you have seen already, where I think we can incorporate the MAC score to help us decide a treatment strategy. We start with a question: is the patient a surgical candidate? If the patient is yes, then you can either do standard surgery if there are no challenges related to calcium. But if there's too much calcium, then you can consider transatrial valve in MAC, either under the Mitral trial or as an off-label. And if the patient is not a surgical candidate, and if the MAC score is 6 or less, then you can consider mitral transcatheter heart valves. If the score is more than 7, then you could consider transeptal valve in MAC if the anatomy is favorable, but then there are other factors that must be taken in consideration, like the risk of LVOT obstruction, for which you could consider alcohol ablation, or lampoon procedure, or radiofrequency ablation. But bottom line is that if the mass score is 6 or less, perhaps you should just go straight to a mitral device. So in summary, valve embolization can occur during valve VIMAC procedures using Sapien transcatheter heart valves. Risk factors include undersizing, underfilling, a too atrial position, and not enough calcium. A CT-based MAC score of 6 or less is associated with a high risk of embolization. Well, thank you very much, and hope to see you in person soon.